Good afternoon. Today we will discuss the topic on myocardial infarction. So, what is myocardial infarction or acute myocardial infarction? It is commonly known as heart attack. It is the interruption of blood supply to the part of the heart causing some heart cells to die. This is most commonly due to occlusion, that is blockage of the coronary artery following the rupture of the vulnerable arterial plug, which is unstable collection of lipid, fatty acid, and white blood cells, especially macrophages in the walls of the artery. The resulting ischemia, that is restriction in blood supply and oxygen shortage, if left untreated for a sufficient period of time, can cause damage or death. Infarction of heart muscle tissue, that is myocardium. So what are the symptoms of acute myocardial infarction or the heart attack? There might be, you might experience sudden chest pain, typically radiating to the left arm or left side of the neck, shortness of breath, nausea, vomiting, palpitation, sweating, and anxiety, often described as a sense of impending doom. Women may experience fewer typical symptoms than men, more commonly shortness of breath, weakness, feeling of indigestion, fatigue. Approximately one quarter of all myocardial infarctions are silent without chest pain or other symptoms. What are the risk factors? Risk factors for atherosclerosis are generally risk factors for myocardial infarction, that is diabetes with or without insulin resistance. A single most important risk factor for ischemic heart disease, tobacco smoking, hypercholesterolemia, more accurately hyperlipidoproteinemia, especially high low density lipoprotein and low high density lipoprotein, high blood pressure, family history of ischemic heart disease, obesity defined by the body mass index of more than 30 kg per meter square, or alternately by weight circumference ratio. 8. Man acquired an independent leg factor of 845. Women acquired an independent leg factor of 855. In addition, individual acquired another independent leg factor if they have a first degree male relative, that is brother father, who suffered from coronary vascular event at or before or 855. Another independent late factor is acquired if one had a first degree female relative, that is mother or sister, who suffered an coronary vascular event at 855 or younger. Hyperhomocysteemia, that is high cysteine, a toxic blood or amino acid that is elevated when intake of vitamin B2, B6, B12 and folic acid are insufficient. Cat occupation with high cat index are known to have susceptibility for atherosclerosis. Alcohol studies show that prolonged exposure to high quantities of alcohol can increase the rate of heart attack. Males are more at risk than females. Now coming on to the pathophysiology, the most common cause of myocardial infarction is narrowing of the epicardial blood vessel due to arteriomatous plaque. Plaque ruptured with subsequent exposure of the basement membrane result in platelet aggregation, thrombopoietin, fibrin accumulation, emulate into the plaque, and varying degree of vasoplasm. This can result in partial or complete occlusion of the vessel and subsequent myocardial ischemia. Total occlusion of the vessel for more than 4 to 6 hours results in irreversible myocardial necrosis, but reperfusion within this period can separate the myocardium and reduce its mobility and mortality. Non-atherosclerotic plaque causes the myocardial infarction include coronary vasoplasm, actin invasion, metal, angina, and in patients using cocaine and amphetamine, coronary emboli, and thrombosis such as infected heart valve. Occlusion of the coronary due to vasculitis or other causes leading to mismatch of oxygen supply and demand, such as acute anemia from gastrointestinal bleeding. There are two types of myocardial infarction, that is transmural and non-transmural. Transmural myocardial infarction is characterized by ischemic necrosis of the full thickness of the affected muscle segment extended from the endocardium to the myocardium to the epicardium. Non-transmural myocardial infarction is defined as an area of ischemic necrosis that does not extend to the full thickness of myocardial wall segment. In non-transmural myocardial infarction, the area of ischemic necrosis is limited to the or endocardium and myocardium. It is the endocardial and subendocardial zone of the myocardial wall segment that are the least perfured region of the heart and the most vulnerable to condition of ischemia. Now coming on to the severity of myocardial infarction, it dependent upon the three factors, that is the level of occlusion in the coronary artery, the length of time of the occlusion, and the presence and absence of collateral circulation. Generally, the more proximal to the coronary occlusion, the more extensive the amount of myocardial at rate of necrosis. The larger the myocardial infarction, the greater is the chance of death because of the mechanical complication or pump failure. The longer the period of vessel occlusion, the greater the chances of irreversible myocardial damage distal to the occlusion. The death of myocardial cells first occurs in the area of myocardium most distal to the arterial blood supply, that is the endocardium. As the duration of the occlusion increases, the area of myocardial cell that enlarges, extending from the endocardium to the myocardium and ultimately to the epicardium. The area of myocardial cell that then fed laterally to the area of the water test or collateral perfusion. The nearly a 10 to 8 hours period of coronary occlusion, that is most of the distal myocardium had died. The extent of myocardial cell that defines the magnitude of myocardial infarction. If the blood flow can be restored to athlete myocardium, the more heart muscle can be saved from irreversible damage and death. Thank you.